Good evening friends, welcome to my channel Critical Care Basics, and in this channel we are putting critical care lectures. The last lecture was on ABG, sample taking and the technical problems. Today's lecture would be on interpretation of acid-base disorders from ABG. So we will focus just on the acid-base disorders today, and later on for oxygenation and other things that we see from the ABG will be discussed later on in a separate video. So this is going to be a little long because I have tried to compress this lecture, a lot of things in this lecture. So kindly see the video till the end and please bear with me. So acid-base interpretation. Role of acid-base balance is very important in the body. The purpose is to keep the maintained pH around 7.40, right? This is the normal pH of the blood. So why this is important to keep a pH of 7.40? Because most enzymes in the body are optimally active when the pH is around 7.4. You can see the enzyme activity here and the pH range here. So see the pH of 7.4. So most enzyme activity is maximum at this pH. There are exceptions to this rule. For example, gastric enzymes work optimally at a pH of 2, but those are exceptions. Most of the enzymes in the body are most active around the pH of 7.4. So what happens if the pH gets disturbed? If the patient develops severe acidosis, for example, what will happen? Patient will have a poor vascular tone, patient will have vasodilation. Most importantly, there could be myocardial pump failure, the patient will go in shock. There will be increased risk of arrhythmias, severe skeletal muscle weakness, electrolyte imbalances, especially potassium. Whenever there is acidosis, potassium will come out of the cells causing hyperkalemia, and whenever there is metabolic alkalosis, the potassium goes inside. So this is the most common. There are other abnormalities also with the acid-base imbalances, so electrolyte abnormalities with their consequent results, and patient can have serious CNS effects like delirium or coma, or lastly there could be impaired cellular respiration causing death. So mostly the pH less than 6.8 is not compatible with life. So to maintain pH, the net acid production should be equal to net acid elimination, right? So where does this acid come from? Most of the eatables that we eat produce acid. So carbohydrates produce CO2 and fats, they produce carbon dioxide around 15,000 millimoles per day. The important is this: the CO2 is a volatile acid, so it can be excreted via lungs as well as kidneys. Proteins produce sulfuric acid, which is non-volatile, about 50 to 100 milliequivalents per day, and phospholipids produce phosphoric acid. So these are the non-volatile acids. These are excreted from the kidneys. So these tend to accumulate and cause acidosis in patients with renal failure. So once this acid is produced, this acid is transported in the vessels through a buffer. So what is a buffer? Buffer is a system composed of a weak acid and a conjugate base, or a weak base and a conjugate acid. And what does this buffer do? This tries to resist the change in pH. So if the hydrogen ions or the acid increases, it will try to provide bicarb and to reduce the acidosis. If there are more bicarb ions, it will try to excrete bicarb or to get CO2 to manufacture H plus ions and try to maintain the pH towards normal. So this is the most common buffer, bicarb CO2 buffer system. CO2 plus water produce carbonic acid. This is very unstable, so immediately gets converted into bicarb and H plus. And so we can remove this from the equation. So what forms is CO2 plus H2O. This requires carbonic anhydrase as an enzyme, which forms H plus and HCO3 plus, and then these can be tackled via various organs to buffer or resist the change in pH. Now the acid is eliminated out of the body through lungs and the kidneys. How does lung eliminate acid? Lung eliminates acid in the form of carbon dioxide. As we have seen in the last slide of the buffer, CO2 forms H2CO3 and with water, and what it forms is H plus ion and bicarb. So once bicarb is absorbed, more CO2 will form more H plus ions, or CO2 will form acid. So carbon dioxide is treated like an acid, right? So this acid will be expirated by lungs. How does this happen? Whenever there is decrease, this can happen through a peripheral mechanism or a central mechanism. So whenever there is decreased pH or increased carbon dioxide, there is stimulation of carotid body receptors, similar to the stimulation when the BP rises. This stimulates the medullary respiratory center and it increases the minute ventilation. What is minute ventilation? Tidal volume multiplied by the respiratory rate. So tidal volume is the amount of air taken by us during one single breath, and multiplied by respiratory rate is the minute ventilation, that is total amount of air that we inhale and exhale in 1 minute. So this minute ventilation is increased and the carbon dioxide is washed out. So the result is decreased carbon dioxide and increased pH. So this is how the lung tries to eliminate carbon dioxide or to reduce the acid, what is called as compensation, right? Another mechanism is a central mechanism. There is decrease in pH of CSF. This stimulates the receptors on the ventral surface of medulla. This in turn stimulates the medullary respiratory center, and the same pathway is followed again. Importance of lungs is, lung can reduce acid rapidly. So elimination of CO2 can be rapid or relatively slow. Hence respiratory compensation could be acute or chronic. While the second organ, that is kidney, that also reduces the acid, but it is slow. So for whenever we talk of respiratory acidosis or alkalosis, there are always two types, acute or chronic, right? Now how do kidneys conserve acid or eliminate acid or conserve bicarb? So this is the proximal convoluted tubule, this is the cell of the proximal convoluted tubule, and this is the urine. Here is the interstitial fluid. So whenever sodium bicarbonate is excreted in the urine, this is the sodium hydrogen exchanger present in the proximal convoluted tubule. This takes the sodium inside and excrete the hydrogen ion, that is acid, into the urine, right? And this hydrogen ion combines with the bicarb to produce H2CO3 or carbonic acid, and carbonic acid splits into carbon dioxide and water. Water is excreted, carbon dioxide is reabsorbed, easily diffuses through the lipid membranes inside the proximal tubular cell. This carbon dioxide, with the help of carbonic anhydrase and water, forms carbonic acid, which splits into bicarb and hydrogen ion. Hydrogen ion is again, with the help of active process using ATP, is excreted inside the urine, and the bicarb is actively reabsorbed into the interstitial fluid. This is how the proximal convoluted tubule excretes the hydrogen ion and reabsorbs the bicarb or the alkali. In the distal convoluted tubule, the hydrogen ions are excreted with the help of phosphates and ammonium. So this HPO4 2- combines with the H plus ions are excreted or actively transported in the distal convoluted tubule from the intracellular area into the urine area, and this combines with the HPO4 2- to form HPO4 1-. So that phosphate, this is a phosphate buffer which is used to take the acid out or excrete the acid. Another buffer is the ammonium buffer. NH3 combines with this hydrogen ions to form NH4. So whenever there is more acidosis, increased quantities of acid must be excreted. The kidney's major adaptive response is to increase the ammonia production, right? So ammonia production is from the glutamine. So kidneys use glutamine to form the ammonia. NH3 combines with the H plus to form ammonium ion. That is why whenever we pass urine, there is a typical smell of ammonia. So this is the smell of the ammonium ion. This is the buffer system used by distal convoluted tubule to excrete acid. So life is a struggle, not against sin, not against money power, but against hydrogen ions. So this was said by McKen. So this is so true. So we have to adopt various mechanisms to conserve the proper acid base milieu inside the body and to conserve the pH. So to go into the ABG analysis, let's start with the simplified or modified Henderson-Hasselbalch equation so that we don't delve into chemistry much more. So hydrogen ion concentration is equal to 24 into PCO2 divided by bicarb, right? So normal hydrogen ion concentration is 24 into 40. The normal PCO2 is 40 and normal bicarb is 24. So there is a range of normal values, but to make things simple and the purpose of calculation, we have kept one single value so that it becomes easy to make mathematics. So the normal hydrogen ion concentration in blood is 40 nanoequivalents per liter. What is pH? pH is negative logarithm of H plus. So whenever hydrogen ion concentration increases, the pH will go down. Whenever hydrogen ion concentration decreases or whenever there is alkalosis, pH will go up. So whenever there is increased hydrogen ion concentration or acidosis, the pH will go down. And whenever there is decreased hydrogen ion concentration or alkalosis, the pH will go up, right? So this is the table. I think you should take a picture of this table and keep with you so that you can immediately see whether the ABG is consistent or valid sample, right? Valid report that given to you. Normal H plus ion concentration is 40, so pH is 7.40. So whenever the H plus ion concentration goes on increasing, you can see the pH goes on decreasing, and whenever the H plus ion concentration reduces, the pH goes above 7.4 and goes on increasing. So whenever we start reading ABG, these are the steps we follow. What is the pH, whether it is acidosis or alkalosis, what is the primary disorder, then what is compensation and is it appropriate, whether it is compensation is acute or chronic, what is the anion gap, and what is the delta ratio. So let's go one by one. First of all, we define the normal values. There is normally a range, but we, as I just told you, we use fixed values so that we can use maths easily. So normal pH is 7.40. So anything less than 7.40 is acidosis. Anything more than 7.40 is alkalosis. Right? Simple. PCO2 is 40. Bicarb is 24. Sodium is 140. Potassium is 4. PO2 is 80. Anion gap, will come to what is anion gap, is 10 to 12 and chloride is 104. So first thing, as soon as an ABG sample is given to you or an ABG report is given to you, first thing you see whether the sample, the data is valid or the data is consistent, right? So how do we do that? We calculate the hydrogen ion concentration and see for the pH. So for example, you have been given an ABG, pH is 7.1, PCO2 is 35, bicarb is 12, PO2 is 70, sodium 142 and chloride 95. So this is the sample. So you calculate the H plus ion concentration, 24 into PCO2 divided by bicarb. So that comes to 70. So again refer to that table. So pH is around 70-71, hydrogen ion concentration is about 70-71. So the pH should be around 7.1. So here the pH is 7.1. So that is matching. So that means the sample is consistent or valid. So this is called step 0. Before attempting, because whenever you go for any exam, to check whether you are doing this step, they give some inconsistent sample sometimes. So always use this and check whether the sample is valid and consistent and then go for step 1. So once we have seen that the sample is consistent or valid, then first we see is the pH, whether it is acidosis or alkalosis. So this is the scenario. Always take into account the scenario so that you get an idea as to what we are expecting. 65-year-old male with CKD. As soon as you say CKD as a chronic kidney disease, the patient is likely to have metabolic acidosis, right? Presenting with nausea, diarrhea and acute respiratory distress, right? This is the ABG. First thing you see is pH is 7.23. So is it less than 7.4 or more than 7.4? Definitely it is less than 7.4. So what should this be? Acidosis, right? So once we have seen that the patient has acidosis, then we have to decide whether it is respiratory or metabolic. So for that you see the carbon dioxide or PCO2. If the pH and PCO2 move in the opposite direction, for example pH comes from 7.4 to 7.2 and PCO2 goes from 40 to 60. So both are moving in opposite direction, then the problem is respiratory, right? Suppose pH goes up and PCO2 goes down, so they are moving in opposite direction, so again the problem is respiratory. Otherwise, in contrast, if the pH and PCO2 are moving in the same direction, for example pH drops from 7.4 to 7.2 and PCO2 drops from 40 to 20, both are moving in the same direction, then the problem is metabolic. For example, pH goes up and PCO2 also goes up. pH goes from 7.4 to 7.5 and PCO2 goes from 40 to 50, then the problem is metabolic, right? So this is step 2. So once you have diagnosed that the patient has either metabolic acidosis, alkalosis or respiratory acidosis or alkalosis, so what are you exactly seeing? For example, if I say the patient has respiratory acidosis, it means that the primary disorder is raised PCO2. The effect is low pH. When I say the patient has metabolic acidosis, that means that the primary disorder is low bicarb and the result is low pH. When I say that a patient has respiratory alkalosis, then the meaning is the problem is PCO2 is low and the result is high pH. When I say that patient has metabolic alkalosis, that means that bicarb is high and the pH is high, right? So what is compensation? As we have discussed some time ago, there are two organs which can eliminate the acid or alkali. So if the patient has acidosis, metabolic acidosis, the lung will try to compensate by increasing ventilation. Right? In metabolic acidosis, the respiratory system will try to normalize pH by reducing PCO2. That is called hyperventilation. In metabolic alkalosis, the respiratory system will compensate by increasing PCO2. For example, if the bicarb is low, so what will lungs do? Lungs will start rapidly taking breaths. We have seen this mechanism, how does it work, and the result will be low PCO2. So if the bicarb is low, this is the primary disorder, the lung will try to compensate by decreasing the PCO2. If the bicarb is high, the patient has alkalosis, metabolic alkalosis, the brain will reduce the respiratory rate and try to increase the PCO2, right? In respiratory acidosis, kidneys will try to compensate pH by increasing the bicarb. So if the PCO2 is high, in the respiratory acidosis, the kidneys will try to increase the bicarb, right, by causing alkalosis. If the PCO2 is low, then the kidneys will try to reduce the bicarb, right? So as you can note from here, the compensation always moves in the same direction. If the main problem is with the bicarb, metabolic problem, the CO2 will move in the same direction as bicarb. If the bicarb is high, the PCO2 will try to move in same direction, the body will try to compensate. Similarly, if the respiratory problem, if the PCO2 high, the body will try to increase the bicarb, and if the PCO2 is low, the body will try to decrease the bicarb. So the compensation will always move in the same direction as the primary disorder. Let's revise this again. So in metabolic acidosis, the problem is decreased bicarb. This is the primary disorder, and lungs will try to decrease the carbon dioxide. In metabolic alkalosis, the primary problem is increased bicarb, so lungs will try to increase the carbon dioxide, PCO2. In respiratory acidosis, the primary problem is increased PCO2, so kidneys will try to increase the bicarb. And in respiratory alkalosis, the main problem is decrease in PCO2, so the kidneys will try to decrease the bicarb. As you can see, the compensation always moves in the same direction as the primary problem disorder. So step 3, 4 is the compensation appropriate. So there are some rules of compensation, not compression. So step 3, 4 is there is appropriate compensation, right? So there are some rules of compensation. For example, if as we have just discussed, in respiratory problems, the acid-base disorders could be acute or chronic, because lungs can rapidly expirate the carbon dioxide, right? So if it is acute respiratory acidosis, for every 10 increase in pCO2, bicarb increases by 1 and pH decreases by 0.08. In chronic, for every 10 increase in pCO2, the bicarb increases by 4 and the pH decreases by 0.03. So you have to memorize this so that you can use this in the mathematics later on. In respiratory alkalosis, for every 10 decrease in carbon dioxide pCO2, bicarb decreases by 2 and pH increases by 0.08. And for chronic, for every 10 decrease in pCO2, the bicarb decreases by 5 and the pH increases by 0.03. So this is the same information in a different format. For every 10 mm change in pCO2, in acute respiratory acidosis, the pCO2 increases. For every 10 increase in pCO2, bicarb will increase by 1 and pH will decrease by 0.07. And if it is a chronic problem, for every 10 increase in pCO2, bicarb will increase by 3 to 4 and pH will decrease by 0.03. Similarly, if it is respiratory alkalosis, that means the pCO2 is going down. For every 10 decrease in pCO2, the bicarb will reduce by 2 and pH will go up by 0.08 in acute conditions. While in chronic condition, if for every 10 mm decrease in pCO2, bicarb will decrease by 5 and pH will increase by 0.03. So just remember this so that you can calculate do the mathematics and reach to a diagnosis. Step 4 is the compensation appropriate. What we have seen, the rules of compensation, they were for the respiratory acidosis and alkalosis. For metabolic acidosis, this is the Winter's formula. Winter's formula is very important because once you see for appropriate compensation, then you can come to know whether there are some additional disorders, right? So Winter's formula is pCO2, expected pCO2 is equal to 1.5 into bicarb plus 8 plus minus 2. So just memorize this. For example, if you calculate pCO2 by this formula and the pCO2 that is actually seen in the ABG is more than the expected pCO2, then there is some additional respiratory disorder. And which disorder? Respiratory acidosis, because the CO2 has increased. Similarly, for metabolic alkalosis, for every 10 increase in bicarb, pCO2 increases by 6. So let's see the application of these formulae. Let's take an example. You have been given an ABG where pH is 7.23, pCO2 is 17, PO2 is 235, sodium 123, chloride 97, bicarb 7, urea 119, creatinine 5. So what is the primary disorder? It is metabolic acidosis. Why? Because pH is less than 7.4. It is acidosis. Why metabolic? Because pH has gone down from 7.4 to 7.23 and pCO2 has gone down from normal value of 42 to 17. So pH has gone down, pCO2 has also gone down. So this is metabolic problem. So this is metabolic acidosis. Now see for the compensation. Expected pCO2 is 1.5 into bicarb plus 8 plus minus 2. So 1.5 into what is bicarb? 7 plus 8, it comes 18.5. So either it should be 16.5 to 19.5. So the result is 17. The pCO2 is 17. So this is appropriate compensation. So correct compensation. So there is only one disorder, primary metabolic acidosis, right? Now the concept of anion gap. Why do we use the anion gap? It helps to differentiate whether metabolic acidosis is due to H plus ion accumulation or loss of bicarb ions. So anion gap is the difference between the major cations and the major anions. So what are the major cations? Cations means the positively charged ions. What are the major positively charged ions? Sodium and potassium. Since sodium is the major single ion, the normal level of sodium is 140, while the normal level of potassium is around 4. So potassium is insignificant. So we remove the potassium for calculating the anion gap. So we use only sodium. And what are the anions? The negatively charged ions. The two important are the chloride and the bicarb. The normal level of chloride is about 104. Normal level of bicarb is 24. So normal anion gap is sodium minus the sum of chloride and bicarb. So 104 and 124, it comes to 12. So normal anion gap is 10 to 12, right? Let us understand this in a pictorial form. So this is the normal serum concentrations. On the left are the cations. So this is sodium, potassium, 4 and some other cations, some positively charged proteins, etc. And what are the negative? The anions, chloride is 106 or 104, bicarb is 23, and then these are the proteins which are charged negatively. So whenever we calculate the sodium minus bicarb and chloride, what we see the difference is actually these negatively charged ions, right? So let's see when the patient, what happens when the patient has high anion gap metabolic acidosis. So the sodium is 140, potassium is 4, the cations are the same. What happens to the bicarb? Bicarb has reduced. Normal level of bicarb is 24. Here the bicarb is 4. What about chloride? Chloride is same. So chloride has not changed. The bicarb is reduced. So what has filled that gap? That gap is filled by some other negatively charged ions. So that is why whenever we see a high metabolic ion acidosis, or you call, in short form you can call HAGMA, or elevated anion gap metabolic acidosis, you say that there is some acid, some toxin either from inside or from outside. Inside means say lactate. So lactate is negatively charged anion, this has increased. Or from outside, for example methanol poisoning. So the methanol is the reason for these extra other anions which have come. So that is the use of this high anion gap. So you can diagnose or scroll down or narrow down your diagnosis to a particular diagnosis. What happens in non-anion gap metabolic acidosis or NAGMA? Sodium is normal 140, potassium is 4. Here the chloride increases, the bicarb has reduced, but the chloride has increased. So there are no additional anions coming from elsewhere, but the chloride has increased. So that is why this normal anion gap metabolic acidosis is also called hyperchloremic metabolic acidosis, right? So in the normal anion gap metabolic acid, there are no other anions that have come from elsewhere, but the chloride has increased and the bicarb has reduced. Anion gap needs to be corrected for albumin, because 50% reduction in albumin results in 75% increase in anion gap, right? So this is the formula. Adjusted anion gap is observed anion gap plus 2.5 into 4.5 minus the measured albumin. For example, in a patient you see an ABG, many ABGs display the anion gap directly, right? So you see an ABG and the anion gap is 10. You think that the anion gap is normal, but then you see that the albumin is 2. So then you have to correct the level of anion gap. So adjusted anion gap is 10 plus 2.5 into 4.5 minus 2. So that comes to 16. So the anion gap is actually high in this patient. So you have to correct the anion gap according to the albumin level. So as we have just discussed, high anion gap means acid dissolves into H plus and unmeasured anion gaps. So H plus is buffered by the bicarb, but this unmeasured anion accumulates. So that causes the high anion gap metabolic acidosis. So in non-anion gap metabolic acidosis, H plus rise is accompanied by rise in chloride. Measurable anion gap, measurable anion, hence the anion gap is not increased. So let's see an example. There is a paramedic, 20 years age, lying in the alley with empty liquor bottle, and BP is 120 by 80, pulse is 110 per minute, respiratory rate is 28, temperature is normal. The patient is unresponsive, pupils minimally reacting to light, DTRs are brisk, plantar are flexor, bilateral basal creps. So what do we get from this picture? This picture suggests that patient has taken some toxin, either alcohol, methanol, whatever. So that is why he is unresponsive and unconscious, and he has crept, so probably he has aspirated, right? So, so history suggests you of ingestion of a toxin. Now this is the ABG. pH is 7.1, PCO2 is 35, bicarb is 12, PO2 is 70, sodium 142, chloride 95, glucose 80, urea 48, creatinine 1.5, and osmolality 327. So let's solve this example. First thing, you see step 0, whether the data is consistent. So you calculate the hydrogen ion concentration, 24 into PCO2 divided by bicarb, that comes to 70. For 70 you should have pH of 7.15. Here in this example the pH is 7.1. So the data is consistent. This is step 0. Then comes step 1. Step 1. What is the primary disorder? So this is our ABG. What is the primary disorder? pH is less than 7.4. The primary disorder is acidosis. PCO2 has also gone down. pH has also gone down. So the problem is metabolic acidosis. PCO2 has reduced and pH has reduced. Both have reduced. Both are moving in the same direction. So the problem is metabolic. So this is metabolic acidosis. So now apply the Winter's formula. Compensation, expected PCO2 is 1.5 into bicarb plus 8. So the PCO2 should be around 25 plus minus 2. But the PCO2 is 35. So expected PCO2 is more, 10 more than the actual PCO2 is 10 more than the expected. What does that mean? There is additional disorder. Because compensation never overshoots. So to compensate for the bicarb, the PCO2 will never overshoot. So if the PCO2 is in excess of what you normally expect by Winter's formula, then there is some additional disorder. And what is that disorder? When will PCO2 go high? It will go high in respiratory acidosis. So there is metabolic acidosis plus concomitant respiratory acidosis, right? Let's go to next step. Let's calculate the anion gap. For every metabolic acidosis, you should calculate anion gap. So what is anion gap? Sodium minus bicarb plus chloride. So what is the sodium? 142, bicarb 12, and chloride 95. So this anion gap is 35. So this is high anion gap metabolic acidosis, right? So there is some toxin either from inside or outside. So these are the causes of high anion gap metabolic acidosis. You can use various mnemonics. For example, mud piles was earlier suggested mnemonic. M starts for methanol ingestion, U for uremia, D for either diabetic, alcoholic or starvation ketoacidosis, paraldehyde, isoniazide, salicylate or iron toxicity, lactic acidosis or ethylene glycol. And if the anion gap is normal, so these are the causes: hyperalimentation, acetazolamide, renal tubular acidosis, diarrhea or diuretics, and ureteroenterostomy or pancreatic fistula. So in our patient, the patient has a high anion gap. So we have to look into these causes. These are another mnemonics. So gold mark is a mnemonic for high anion gap metabolic acidosis. G for glycols, O for oxoproline, L for L-lactate, D for D-lactate, M for methanol, A for aspirin, R for renal failure, and K for ketoacidosis. Or the simplified one is CULT. K for ketoacidosis, U for uremia, L for lactic acidosis, and T for all those toxins that we have mentioned earlier. So once we know that our patient has a high anion gap metabolic acidosis, right? So the next step is to calculate the delta ratio. Delta ratio is calculation that compares the increase in anion gap to the decrease in bicarb concentration, right? So delta ratio, there is also delta gap where this decrease in bicarb is negated from the increase in anion gap, but the delta ratio is more accurate, so we will only talk about delta ratio. So delta ratio is measured anion gap minus normal anion gap divided by normal bicarb minus measured bicarb, right? Let's try to understand what is delta gap before going ahead in this example. So what happens normally in a normal person with a pH of 7.4, we have already seen this, the sodium is 140, potassium is 4 and the rest are unmeasured cations. Chloride is 104 or 106, bicarb is 24, and these are the unmeasured anions which are measured as anion gap. So normally sodium is 140, bicarb is 24, chloride is 104, the 140 minus 128 is 12. So anion gap is normally 12. In high anion gap metabolic acidosis, what happens? Sodium is 140, potassium is 4, chloride is 104, chloride has not increased, the bicarb has reduced, and this is compensated by unmeasured anions which are raised. So the anion gap has increased. What is the anion gap? 140 minus 14 plus 104, that is 24. Now here, what is the bicarb, change in bicarb? Normal expected bicarb is 24, here the bicarb is 12. So 24 minus 12 is 1. What is the given anion gap in this? 24. What is normal anion gap? 12. So 24 minus 12, so numerator is 12, denominator is also 12, so the delta ratio is 1, right? So in HGMA, if there is no additional disorder, the delta ratio should be around 1. If the HGMA is complicated by one metabolic alkalosis, for example, a patient of renal failure has high metabolic acidosis, high anion gap metabolic acidosis, and he is persistently vomiting or severely dehydrated and also develops, say, metabolic alkalosis. So what will happen? Here the anion gap is same, sodium 140, but the bicarb here has increased, right? So 140 minus 18 plus 98, and the chloride has decreased. In metabolic alkalosis, the chloride has decreased and bicarb increased, but the sum of these two is same, so the anion gap is same. So what is the change in anion gap? 24 minus 12 is 12, so the numerator is 12. And what is the bicarb? The bicarb has increased. There the bicarb had reduced, here the bicarb is increased. So what is the change in bicarb? 24 minus 18 is 6. So the denominator has reduced, so here the delta ratio is 2. So whenever in high anion gap metabolic acidosis, if the delta ratio comes 2 or more, that means the patient has high anion gap metabolic acidosis plus metabolic alkalosis, right? Let's see what happens if the patient has high anion gap metabolic acidosis plus non-ion gap metabolic acidosis. This is, we have seen the normal person with a normal anion gap, same, the anion gap is 12. This is also the same figure in our last slides. Let's see what happens to delta ratio when high anion gap metabolic acidosis is associated with a non-anion gap metabolic acidosis, right? This is the left side of this diagram is same as in the last slide. This is the normal person, anion gap of 12, sodium 140, potassium 4, chloride 104, bicarb 24. This is the pure high anion gap metabolic acidosis. The anion gap is 24, the bicarb has reduced, and as you have seen, the numerator and denominator is both 12, so the bicarb ratio or the delta ratio is 1. What happens when the patient has high anion gap metabolic acidosis plus non-ion gap metabolic acidosis? Here the anion gap is same because the bicarb has reduced but the chloride has increased. So the sum of bicarb plus chloride remains same. So anion gap is 140 minus 18 plus 98 is equal to 24. And anion gap is same, but what happens to bicarb? The bicarb is 6. So 24 minus 6, normal bicarb is 24, minus 6 is 18. So the numerator is same, the change in anion gap is 24 minus 12 is 12, but the change in bicarb is 24 minus 6 is 18. So the delta ratio is 12 by 18 is 0.7. So if the patient has a delta ratio of less than 1 in a patient with anion gap metabolic acidosis, probably the patient has high anion metabolic acidosis plus a non-ion gap metabolic acidosis as well. This is the same whenever in high anion gap ratio, when the delta ratio is less than 4, then there is hyperchloremic or non-ion gap metabolic acidosis in addition to hagma. When it is 0.4 to 0.8, it is hagma plus nagma. When it is 1 to 2, there is uncomplicated high anion gap metabolic acidosis, and when it is more than 2, there is metabolic acidosis with pre-existing elevated bicarb, that is metabolic alkalosis or respiratory acidosis in addition to high anion gap metabolic acidosis. So whenever you are doing a delta ratio in a patient with high anion gap metabolic acidosis, if the ratio is between 1 to 2, this is the ratio that is usually expected in lactic acidosis, while in ketoacidosis the delta ratio is lower, 0.8 to 1.2, unless the patient has exceptionally low GFR. In kidney disease it is variable, and in ethanol glycol poisoning it is around 1 to 2. So let's see what happens in our example. So our example is about the guy who had fallen unconscious after taking some poison, right? And we had seen that patient had metabolic acidosis, and it was high anion gap metabolic acidosis. Patient had also respiratory acidosis. So we have already diagnosed that the patient has high anion gap metabolic acidosis and the patient has respiratory acidosis as well. Now in this case, what is the delta ratio? Change in anion gap divided by change in bicarb. So anion gap is 35, the expected normal anion gap is 10, divided by normal bicarb is 24, and the bicarb in this patient is 12. So it is 2.08. What does that mean? This is anion gap metabolic acidosis plus respiratory acidosis plus metabolic alkalosis, right? So this is a mixed disorder. The patient has anion gap metabolic acidosis plus respiratory acidosis and metabolic alkalosis. So in anion gap metabolic acidosis, always calculate the delta ratio so that you can further pinpoint the problem. Lastly, in this particular example, we would also calculate osmolar gap. Osmolar gap or serum osmolar gap. What is osmolality? Osmolality is the thickness of or the solute load of a liquid sample. So normally there are two types of osmolalities. One is the calculated by a formula and one is actually measured, right? Here in our lab we don't have the facility to measure osmolality. I think no lab in Jabalpur is measuring osmolality as of now, but if you have a measured osmolality and the calculated osmolality is different, then you can get an idea as to what is osmolar gap and you can further diagnose this patient. If this difference is between calculated and it is the difference between calculated and measured osmolality. Calculated P osmolality is calculated by this formula, 2 into sodium plus glucose divided by 18 plus BUN divided by 2.8. Where does this 18 come from? 18 come from the molecular weight of glucose and urea respectively. Normally measured osmolality is 280. And normally measured osmolality is higher than calculated osmolality by 10. Most probably it is less than 20 higher than the calculated value. Larger values indicate the presence of osmotically active substances. So here we are given urea and we are given measured osmolality as well, we are given glucosol. So what is the calculated osmolarity? 2 into sodium plus glucose divided by 18 plus urea divided by 2. So 2 into 142, 142 is the sodium, 80 is the glucose divided by 18, and 48 is the BUN divided by 2.8. So we get a value of 305. And what is the measured osmolality? 327. So normally the difference should not be more than 20. So here the difference is 327 minus 302 is 22. What does this suggest? High osmolar gap suggests that patient has some osmotically active substance in the plasma, like methanol, ethanol, or ethylene glycol. So now what is the final diagnosis is in our patient? The patient has taken some toxin that is osmotically active. So either he has ingested one of these substances, methanol, ethanol, or ethylene glycol. That is why he is unconscious. So the patient is breathing slowly and has respiratory acidosis. The patient has metabolic acidosis as well, high anion gap metabolic acidosis, and the patient has in additional metabolic alkalosis. So the patient has ingested some toxin of the above. So this is how we approach the patient of ABG for acid-base analysis. I have not given many examples. So if you suggest, we will make a separate video for examples only, because this was becoming very longer. So I kept minimum examples to drive the concept home only. If you are liking these videos, please like, subscribe and share. Bye bye.